So good evening, everyone. Welcome to our second webinar in the Epidemic and Pandemic Preparedness Program's webinar series. The webinar series is hosted by the Global Health Institute at the American University of Beirut. So for today's session, we will be talking about the field lessons from Lebanon's cholera responses and discussing implications and challenges beyond borders. So before we get started, I'd just like to clarify that the webinar is being recorded and will be uploaded on our YouTube channel. Please feel free to drop your questions in the Q&A box below, and we'll attend to your questions at the end of the webinar during our Q&A sessions. I'd like to introduce our moderator for today, Dr. Atika Birri. Dr. Birri is the head of Preventative Medicine Department at the Ministry of Public Health, Lebanon. Thank you all for joining, and Dr. Birri, I will leave the floor to you.
Thank you.
Thank you, Sarah. Hello, everyone. To begin with, I would like to thank the Global Health Institute Epidemic and Pandemic Preparedness Program at the American University of Beirut for hosting this important webinar. I will start with a small briefing of the outbreak that happened during the year 2002. At the end of 2002, Lebanon faced its first cholera outbreak in decades. This outbreak, which originated from an informal refugee settlement in northern Lebanon, posed significant public health challenges and tested the preparedness and resilience of the country's health system. Following the declaration of the first few cases, the Lebanese Ministry of Public Health established a coordination mechanism with multi-sector partners, which led to a rapid response and control of the outbreak. Now, what's cholera? Cholera is an acute enteric infection caused by ingesting the bacteria Vibrio cholera present in contaminated water. This bacteria can spread rapidly depending on the frequency of exposure, the exposed population, and the environment. Cholera affects both children and adults and can be fatal if untreated. Today, we have three esteemed experts who will share their on-ground experiences and insights into these critical aspects of surveillance, diagnosis, and case management of cholera. Their expertise will underscore the success and challenges of the Lebanese response, offering lessons that go beyond geographical boundaries, providing information that can strengthen regional preparedness and resilience against future cholera outbreak. Allow me now to introduce our first speaker, Dr. Bizri. Dr. Abdurrahman Bizri is an internal medicine and infectious disease specialist at the American University of Beirut Medical Center and a founding member of the Conflict Medicine program at AUB's Global Health Institute. He has been actively involved in infection control programs, both at the national and international levels. Dr. Bizri's experience covered the changing epidemiology of infectious diseases, including cholera, salmonella, viral hepatitis, and emerging pathogens. He's contributed to over 100 publications on infectious disease and served as a WHO expert and advisor on transmissible diseases with a special focus on infections in conflict zones. Dr. Bizri will present the clinical aspects of the disease, including case management and treatment aspects. Dr. Bizri, the floor is yours.
Thank you, Dr. Birri. Thank you, Atika. And thanks again to the Global Health Institute for arranging these very educational and interesting seminars, and definitely for inviting me with this distinguished panel. Let me start, first of all, by starting with a real case. This is a true case, and this case was probably one of my earliest experiences with cholera. This is a 47-year-old Lebanese lady. She's an artist, and actress, and an entertainer. She presented to the emergency department on September 2, 1993, at the American University of Beirut, complaining of severe watery diarrhea. The incriminated food then was probably a very large wedding party one day before her presentation, and this lady was probably performing in that wedding. So her in-hospital course when she was admitted was quite severe, with profuse diarrhea and profuse diarrhea, hypovolemia, electrolyte disturbances. We were afraid that we are going to lose this lady, despite the fact that she was not old and she didn't have a lot of underlying comorbidities, and had really a very difficult problem. This was my first experience with cholera. Had a difficult problem trying to treat her and manage her. The severity of the illness urged us to consider the unusual. And this is why, on top of our routine stool cultures, we ordered a TCBS media, which I will talk about later, to look for potential cholera. And it turned out to be a positive for Vibrio cholerae. So this was really the first case of Vibrio cholerae seen then in 1993 in Lebanon. So because of that, we took the liberty of contacting the people who were in the wedding, and we contacted probably the families of the bride and the groom, all of them, and we discussed the case, and we discovered that dozens of people were admitted to other hospitals complaining of severe watery diarrhea. So this was really our first index case. And this is why this case was diagnosed, because we had really very high index of suspicion despite the lack of epidemiological data. There was no cholera then in the country. There was no recent history of travel for this lady anywhere else outside Lebanon. And this is why we insisted on epidemiological investigation of that case. And this was really a large, the first case of a very large cholera outbreak in Lebanon that unfortunately resulted in significant morbidity and significant deaths in the country. And I don't want to go through why this happened. So cholera, as Atika mentioned, is an acute watery bacterial diarrheal disease caused by Vibrio cholerae. It is usually the disease of poor poor people, and those who have inadequate access to safe water and basic sanitation. The emergence of a lot of conflicts and wars and the presence of refugees, the unplanned urbanization, climate change, all of these contribute to the increased risk of acquiring cholera, where we believe that around 1.3 to 4 million cases annually of cholera occur, with around significant morbidity and deaths all over. Most of people who acquire cholera will have no symptoms or mild symptoms, but those who have mild symptoms can be successfully managed with oral rehydration solution. Severe cases may need hospitalization, rapid fluid infusion, and antibiotic. Safe water, basic sanitation, hygiene practices are critical to prevent and control the disease. Luckily, we have oral vaccines that if we couple them with improved sanitation, we can prevent further outbreaks. The portal usually is ingestion of contaminated food and water. The spectrum of the illness is quite wide. People always think that cholera is a very severe illness. Yes, it can produce severe illness. However, the illness can be mild and can be asymptomatic. Yet asymptomatic individuals can shed bacteria up to 10 days after acquiring the bacterium. The incubation period can vary from half a day, 12 hours, to up to 5 days, with an average 1 to 3 days. We know that several pandemics have occurred in the past. The latest pandemic is the 7th pandemic that started in 1961. However, we can encounter cholera as endemic or in epidemic. Well, the endemic form is usually seasonal and occurs mostly in children below 5 years of age. The pandemic form is responsible for major outbreaks. The clinical manifestations of cholera do vary, but you can have vomiting, which sometimes may precede or come after the onset of diarrhea. There is usually no or minimal abdominal pain or cramps. It is classically watery diarrhea, but in the early stages of the diarrheal illness, stools may contain fecal material and bile material. So severe cholera, or what we call cholera gravis, produce ricey water stool, which is usually watery stool with flecks of mucus. It has a fishy odor, and it's usually a painless diarrhea with no tenesmus. Stool output can be as high as 1,000 ml per hour, given that usually we produce 1 ml every 1,000 ml every hour. We can estimate that the volume loss sometimes over one or few days can be almost 100%. So this is really severe, and if we don't replace it, our patients will collapse and die from shock. Fever is rather uncommon, and 5 to 10% of people who have diarrhea will produce this severe form and will go into shock. And some people will die not only from shock, but also from electrolyte imbalance and from severe acidosis. The transmission is usually via the fecal-oral route. Transmission within household or between close contacts can occur. Outbreaks are usually related to contamination of the source, whether the source was the food or the water. And this is what have happened recently in Lebanon in 2022, where there was contamination within the source, mostly the water. The infectious inoculum, because usually cholera is acid susceptible. The Vibrio cholerae is acid susceptible. We need usually a large inoculum to get the disease. So usually the infectious inoculum dose can be up as high as 10 to the 8. And individuals with severe cholera will excrete around 10 to the 12 organism per liter of stool. So imagine the amount they excrete. If they can excrete 1 liter every hour over 24 hours. So this is a huge number of organisms that are contaminating the environment. So since dehydration and the electrolyte imbalance are the most important, as the most important signs of severity here, then this is why we really need to have assessment of the dehydration. If our patient is well and alert with normal eyes, drinks normally and not feeling thirsty, the skin pinch, which means that if we press on the skin and the skin pinch goes back quickly, then the estimated fluid deficit is less than 50 ml per kilo, and our patient can be sent home on oral hydration solution to be monitored. If our patient has 2 or more of the following signs: restlessness, irritability, sunken eyes, very thirsty, drinks eagerly, skin pinch goes back. If we pinch the skin and it goes back very slowly, then the estimated fluid deficit is 50 to 100. We have to monitor our patient, preferably admit them to receive fluid, whether orally or via IV, and monitor them. If there are more than 2 or more of the following sign: lethargy, unconscious, sunken eyes, unable to drink, or drinks very poorly, skin pinch goes back very slowly, takes more than 2 seconds for the pinch to go back normally, then the estimated fluid deficit is over 100. This patient needs aggressive IV fluid hydration and probably antibiotics to manage them. The composition of oral hydration solution can vary. We have the IV, we prefer to give either lactated ringer solution, which contains sodium, potassium, chloride, and bicarb. We usually prefer this. However, we can give IV normal saline, which has a higher volume of sodium, but has no potassium and no bicarb. And the chloride, so this may predispose to lactic acidosis. We have to supplement this with bicarb and potassium as well. We have IV chlorosaline. It's called the DACA solution. This is made mainly for cholera, which has sodium, potassium, chloride, and high amount of bicarb. And it has a lot of carbohydrate here. This is usually very important. We have the oral hydration solution that can give to mild and moderate cases. We have the ORS standard one with sodium, potassium chloride, and bicarb and citrate, and also carbohydrate. We have the WHO 2002 ORS solution, which contains these. And as you can see, we have the rice-based ORS, chloride, bicarb, and as you can see, the presence of carbohydrate is important. We need to have in our ORS either glucose or rice or starch. Why do we need this glucose in our ORS solution? Because it will help in the reabsorption of sodium that we have lost. Importantly, the addition of zinc to the oral hydration solution or to the IV solution is important, especially in children. Zinc will probably also facilitate the reabsorption of erythrocyte. Some people will advocate the use of vitamin A, and mainly in children, high caloric diet is very important. The microbiology of cholera, as you know, is usually Vibrio cholerae is the causative incriminated pathogen. However, we have to remember that watery diarrhea can be produced by many other several bacteria, including enterotoxogenic E. coli and other bacteria. However, there are other Vibrio that are involved in diarrheal diseases, mainly Vibrio vulnificus and Vibrio parahemolyticus, but they usually mainly cause what you call inflammatory type of diarrhea, not usually watery type of diarrhea. To go back to the Vibrio cholerae, we have several serogroups, mainly only two, 01, 01, and 0139 cause outbreaks with similar disease spectrum. So the 01 serogroups and the 0139. The Vibrio cholera 01 has caused all recent outbreaks. So most of the recent outbreaks are caused by Vibrio cholerae 01. The most of the older outbreaks was caused by 0139, which is still responsible for certain what you call sporadic cases and never seen outside Asia. Based on the biochemical structure, we have two biotypes, the classical cholera, which we are seeing less and less, and the Altor, which we are seeing more, especially the more recently altered Altor biotype. And each biotype can be differentiated into three serotypes, Ogawa, Indaba, and the more rarer form of Hikujima. To diagnose cholera, we really need to have a clinical suspicion, whether the suspicion is epidemiological, somebody coming from a cholera plagued country, or we know has cholera, probably travel in Lebanon to a cholera area, or living in an area where cholera was recently identified there, plus signs and symptoms suggestive of severe watery diarrhea. The laboratory tests are very helpful. We have the general test, the hematological test, the chemical test to detect electrolyte imbalance, acidosis, and dehydration, all of them, and renal failure that occurs as a result of pre-renal azotemia, because we have been having contracted volume and we have lost a lot of fluid and electrolyte. When it comes to stool test, we have a lot of stool tests to do. We can do gram stain on stool or look at dark field microscopy on stool. They are very quick. They are not very expensive. And by gram stain, it will stain a comma-shaped gram-negative blood. But and this is, we can do it quickly, and this is very cheap. We can do PCR on stool. This is more expensive, but we can do it on site. And these PCRs are as what you call as sensitive as what you call a stool culture and can give you the result much quicker. We know now that we can have multiplex PCR that can, or an assay of stool that can really tell you, you can get more, you can get to diagnose it or diagnose other causes of diarrhea. The culture, we have to have special culture media, mainly TCBS media or TTGA. You can do that on regular stool or on stool swab. And we have rapid diagnostic tests that are sensitive, however, sometimes falsely positive. So this is the life cycle of diarrhea in our community, in humans. So you can get diarrhea from water or stool. You can have it as if you can have a cholera outbreak. This Vibrio cholera will be polluted, the source, and you have to have a high inoculum, and then you're going to have the disease. To conclude quickly, can we use antibiotics to treat cholera? Yes, we can use them, but they are only needed if you have severe cases. In mild to moderate asymptomatic cases, no need to use them. They are only recommended in severe disease. Antibiotics will shorten the length of infectious diarrhea, and this is very important if we have large cases of diarrhea, because shortening the length of diarrhea will shorten the need for hospitalization, will shorten the need for stay in hospital, will shorten the requirements for IV hydration and electrolytes, especially in very huge, large outbreaks. They can also decrease the volume of stool output by 50%, and this will decrease also the shedding of the bacteria in the community and help later to prevent further cases. That the antibiotics used are tetracycline or mostly doxycycline, azithromycin, fluoroquinolones, and cotrimoxazole. Of course, there are many other antibiotics that can be used, but we don't like to use them left and right in moderate cases because we are fearing the emergence of resistance. For prophylaxis, they can be used in the close contact, especially at home, if we have a critically ill patient, to prevent the propagation of the illness inside a closed community or at home, or in what you call, let's say, in a home care setting for the elderly, in a shelter or so. They are effective in reducing the incidence of the clinical disease and its severity, so they can be used, but beware, don't use them at a large scale, because this will contribute to the emergence of resistance. We have vaccines that probably will be talked about later by other speakers. We have one vaccine which is approved by CDC and used in the United States. It's one single dose vaccine that confers brief duration of protection. In Lebanon, we probably have used this vaccine in 2022 when we combated the outbreak that Dr. Berry has referred to, and we have given only one dose out of two, and one dose will give you probably a protection between 6 months to 1 year, and this should be enough to curb the outbreak, to contain it. Now we are using this vaccine once again to prevent versus propagation of a potential outbreak, because cholera have been witnessed in Syria and in the areas close by where we have seen a lot of Syrian refugees or in and out of Syria. Now the Ministry of Health is giving these vaccines. The case too quickly is a lady that probably very well to do. She's a physician. She had dinner, Thanksgiving dinner with the family members. And this Thanksgiving dinner, nobody have diarrhea except this lady. So all other people who ate the same food never had diarrhea except this lady. However, when she presented, I was also the physician then. When she presented, this lady had severe diarrhea. So had severe diarrhea. We suspected cholera because we were about to lose her and we took her to ICU. We took TCBS stool culture. It turned out to be Vibrio cholerae. And this was the only case. No other cases appeared. and no family member had diarrhea. The risk factor was what we call achlorohydria. This lady had very suppressive acidity in her stomach, and she had a peptic ulcer surgery in the past. And this is why she was the only lady, because of a small inoculum, she acquired diarrhea. And this is tell us that we can still have sporadic cases of diarrhea, and we need really to investigate them and to look for a potential source of diarrhea. So cholera in Lebanon, to conclude, we know that cholera is a major public health problem in low to middle income countries. We know that Lebanon now has been transferred, according to World Bank, from high middle income country to low middle income country. And we know that we have a problem with sanitation and hygiene. So this is why we expect cholera to reappear again in Lebanon, and we have to keep very vigilant eyes, and this is where the Ministry of Health is keeping good vigilance. We know that in 1993 we had bad response. In 2022 we had excellent response, and now we have a risk of importation, and now we are trying to contain it by vaccination. So to conclude my talk, really, Lebanon is at high risk of water and foodborne diseases, mainly cholera and other diarrheal illnesses. There is the risk of a new cholera outbreak is always there because of poor sanitation and failed infrastructure, scarcity of adequate water for human utilization, the refugee burden, the global warming, and the extreme weather events. Lebanon has managed to contain a recent outbreak in 2022. Healthcare providers should consider cholera in their differential when handling any diarrhea case that really appear to be severe, and we have to keep an open mind about the potential of diarrhea. And to conclude, to recommend that the availability of oral cholera vaccine should always be there. I know they are being used now, and potential early implementation in high-risk population and in high-risk areas. And this is what the Ministry of Health is doing, educating and alerting healthcare providers on the risk of cholera for early recognition, because early recognition can prevent further spread. And the coordinated efforts between Lebanese Ministry of Public Health, the UNICEF, the WASH section, WHO, UNHCR, UNRWA, and other donors, plus the medical and public health community is important in order to protect our country and prevent further propagation of cholera and during these hardship times. Thank you.
Thank you, Dr. Bizri, for this interesting presentation. Now, due to the lack of time, we'll be moving directly to Dr. Ghosn, our next speaker. Dr. Nada Ghosn is a medical doctor specialized in public health. She's the head of the epidemiological surveillance program at the Lebanese Ministry of Public Health for over 20 years. She contributed to various WHO missions, including trainings and reviews for more than 10 years. In addition, she's a lecturer at the Faculty of Public Health at the Lebanese University. Dr. Ghosn will present the surveillance activities and the national epidemiological data during the last outbreak, highlighting the importance of early detection in containing the spread of the disease. Dr. Ghosn, the floor is yours.
So good evening, everyone. It's a pleasure for me to present the cholera outbreak in Lebanon in 2022-2023. We will see the context and then the methodology and the results and the challenges that we have faced during this period. So to start, I will go to the context in Lebanon. As Dr. Bizri said, in 1993, Lebanon has witnessed an outbreak of cholera with more than 300 cases. So it was Vibrio cholera or one subtype of Gawa. The reporting was from the hospitals, public and private, and cases were reported from all the muhafaz, especially from the north and Dakar. And also we had cases from the long stay has facilities, and the estimated number of cases were around 3,000, and the case fatality was among reported 7%, and among the estimated was 3%. The sources at that time was fecal contamination of the water and mobility of foreigner construction workers, and also having carriers among healthcare workers. So this was in 1993. If you go now to 2022, in the world, we are still in the seventh cholera pandemic, and globally we have witnessing an increase in the cases compared to 2021. So in 2021 we have more than 200,000 cases, but I've lost my slide. I'm going back to my slide. Okay, so and in 2022 we had more than 400,000 cases reported. Okay, I'm having problems with sharing the
It's okay,
slide.
I'll share. I'm sharing for you, no worries.
I prefer to share to do it by myself, not to say every time next.
It's giving a black
So,
screen from your end, this is why.
okay, fine. So can you go next, please? Okay, and if we compare 2021, we had 35 countries reporting cholera, and in 2022, there were 44 countries. And when we look to the countries with more than 1,000 cases, in the list we have Afghanistan, Syria, Nigeria, DR Congo, Malawi, Somalia. So different countries have cholera outbreak in 2022. Next slide, please. So now let's go back to Lebanon. So in October 2022, we had a call from a hospital in the north reporting a suspected cholera cases among Syrian refugees from informal settlements. On the same day, the stool sample was referred to the EUBA research laboratory. The next day, we had a field visit to the place of residence of the Syrian case. It was an informal settlement, as in the picture. We requested stool from the household and the neighborhood, and the result in the afternoon for the case was Vibrio cholera documented. The Vibrio cholera identified was O1, subtype Ogawa, serotype 69. Next slide, please. So the objective of the investigation was at that time to confirm the outbreak, to monitor trends and propagation, identify high-risk groups and risk factors, and to confirm containment once it's done, and to provide timely information for decision makers. Next slide, please. So the key definitions depends on the area. If you are in a cholera-free area, yes or no. If you are in cholera-free area or locality or CASA, it is any suspected case, meaning acute watery diarrhea with complications, meaning with dehydration or death. And confirmation was to have confirmed Vibrio cholera by culture or PCR with toxin production documented. If you are in a cholera-affected area, any acute watery diarrhea is a suspected case, and confirmed case was confirmation by culture or by PCR. Next slide, please. As for the investigation, so we collected data about demographics, clinical presentation, travel history, underlying conditions, case management at facility, vaccination during the campaign. And also we collected data about what are the sources of drinking waters and what is the sanitation infrastructure, and also what is the situation of the contacts. Next slide, please. As for the confirmation, to confirm at that time, the rule was to have a culture. So in cholera-free area, we had to test any suspected case, starting with RDT if available. If not available, we have to do the culture. If we are in a cholera-affected area, no need to test all cases. So we have to take 10% of the cases suspected to be tested. If available, we do a rapid test. If not available, we do go directly to the culture. Next slide, please. So as dates, on the 6th of October 2022, the MOPH have declared the outbreak in Lebanon. And the second day, we had the second case. It was a healthcare worker who had been taking care of the first case, who also was confirmed having cholera. 8 months later, in 2 June 2023, the end of the outbreak was declared by the MOPH after several months of negative culture for cholera. Next slide, please. So we see that in October, November, we have an increase in the numbers, and we have a peak at end of October. This was a peak in Bebnin. It's a locality in Akkar. Most of the cases at the beginning were in Akkar and Minidaniye, and later we had cases in other muhafaza. As a total number of total cases suspected and confirmed, we have reached 8,007 cases. Among them, we had 6,771 confirmed cases, and the last confirmed case with culture was in February 2023. Next slide, please. Here we have the mapping. So the first one is the attack rates by Gaza. So you see that highest attack rates was in Akkar, Minidaniye, Tripoli, but also in Baalbek and in Zahle. If you go to the localities with confirmed cases, so we see that in Akkar we have a lot of localities with confirmed cases, also in Minidaniye, in Tripoli and around Tripoli, and also in Arsel and the Baalbek and Zahle and West Bekaa, also in Beirut suburbs, also in Mount Lebanon and Saida and Sur. If we look to the distribution of the cases by age group, more than 50% were under 15 years old. And if you go to distribution by gender, 53% were females. As per the nationality, 62% were Lebanese and 32% were Syrian. So we had a lot of Lebanese cases during this outbreak. For the next slide, please. So we have here the deaths. So we have 23 deaths documented during this outbreak. The case fatality rate was 0.3%, and 16% of the cases were admitted to hospitals. Also, we have took samples from the water, drinking water, domestic water, agricultural water from the areas, and we have confirmed the presence of cholera in this area. So we had contamination of the water in the north and also in other areas where we have clusters of cases. Next slide, please. During the outbreak, we had daily surveillance report issued by the EPaPP and posted on the EPaPP website in order to monitor about the trends and the propagation of the outbreak. Next slide, please. And the response with as needed multi-sectorial response. It was with a coordination leadership of the EPaPP, and the first actions is to ensure safe water and adequate sanitation for the population, and this in coordination with the Ministry of Water and Energy and the water sector. Also, there were a lot of activities for the health awareness for the public about hand hygiene, but also about putting chlorination, chlor in the water reservoir. And also we have enhanced surveillance, active search, and using the call center for the population. And also there were training for the health facilities about case management and infection control practice. And at the end also the cholera vaccine have been requested, and the campaign has been launched with 1 dose for the hotspot areas. Next slide, please. Here I will talk about challenges that we have faced during this outbreak. I have 4 challenges. The first one, laboratory capacity. When we had the first case reported as suspected, no public laboratory was available to do that test. So we had to refer to the AUB. I think the AUB to be there when needed. So, but this is a lack that in the public sector, no lab was available to do this test. Later, weeks after weeks, there is a lot of work with WHO to train the public hospitals about cholera testing and to have the procurement and to have as reference labs the AUB and the Rafiq Hariri Hospital. So today, as in 2024, the public hospitals at Muhafaza level are still capable to do the culture for cholera. Next slide, please. Another challenge that we have faced is the procurement of cholera rapid test. It's very important when we have an outbreak of cholera to have the rapid test available. This is very important. During the peak, at the beginning, no rapid tests were available. So when we had to confirm a case, we have to do directly culture, and the high demand of the culture have led to shortage in consumables for the culture. And when we had the cholera rapid test available, it was after the peak. So we have used this cholera rapid test to document the end of the outbreak. So we didn't have the rapid test during the peak and not before. We have it only at the end of the outbreak. So it's very important for the country to have a stock of rapid tests available if we are at high risk of cholera outbreaks, because when we have an alert, we can use them rapidly. So this is very important for us to maintain a stock of cholera rapid tests in the country. My third challenge is to think about one health approach. At the beginning of the outbreak, we didn't have this exchange of results about water tests between different sectors. As you know, cholera outbreak means that we have problem with the water. So by the end of the outbreak, we have established some links between different sectors to exchange the lab result for the water. And today we have a dashboard, shared dashboard with different partners where we exchange the result of the water testing. Because if you see that we have an alert, we can directly ask for measures to prevent the occurrence of any outbreaks linked to the waterborne diseases. And for the last challenge that I want to mention is about having safe water and adequate sanitation. As I've said, if we have a cholera outbreak, this means that we have a gap in water safety and sanitation. I will take the example of 2022 in the United Arab Emirates. So at that time, this country had reported 37 imported cholera cases, but no outbreak has occurred because they had a good sanitation system and they are providing the population with safe water. But in Lebanon, in this same year, in 2022, we had an outbreak with 2 identified strains, one from Syria and one from Yemen, and they have led to a large outbreak in the country with 23 deaths. So this is my main message for the people. If we have a cholera outbreak in a country, this means that we have a problem with the water safety. And here I thank you very much. I thank my team, the Ministry of Public Health teams, the health facilities, the AUB, the laboratories, the UN agencies, and the NGOs. Thank you very much.
Thank you, Dr. Ghassan, for this very interesting presentation. We'll move now to our last speaker, Dr. Ghassan Matar. Dr. Matar is a professor and chairperson in the Department of Experimental Pathology, Immunology, and Microbiology. He is a co-director of the Center of Infectious Disease Research and the director of the WHO Collaborating Center for Reference and Research on Bacterial Pathogens at the Faculty of Medicine at the American University of Beirut. Dr. Matar has published 140 articles in international journals. He has many research interests such as molecular epidemiology of foodborne pathogens, molecular mechanism of resistance to antimicrobial agents in pathogenic bacteria, and others. Dr. Matar supports the Lebanese Ministry of Public Health in lab diagnosis activities related to many communicable diseases. Dr. Matar will present the importance of lab diagnosis in cholera, sharing insights into the methods used to confirm cases and monitor the outbreak. Dr. Matar, the floor is yours.
Thank you, Dr. Berry, for inviting me to this very important webinar and to the Global Health Institute for hosting it. Sarah, would you please let me share my screen? Can you all see it?
Yes, doctor, we can see.
Okay. So in this talk, I'm going to highlight the detection of an unusual 2-strain cholera outbreak in Lebanon through our genomic epidemiology study. So before talking about cholera, I'd like to highlight the structure and the role of our WHO Collaborating Center at AUB. Now it's located at the Faculty of Medicine, and it is a designation of the Department of Experimental Pathology, Immunology, and Microbiology, and the Center for Infectious Diseases Research. So the terms of reference are to support WHO by contributing to a better understanding of circulating bacterial pathogens for the purpose of monitoring, tracking, and combating through, especially combating AMR, through research, to serve also as a training center and as a laboratory diagnostic support laboratory at the regional and global level, as well as at the local level, for the identification and characterization of bacterial pathogens, for surveillance purposes and for emergency outbreak response. Now, the activities of the center is to implement whole genome sequencing and diagnostic and surveillance of AMR and PulseNet genotyping. Also, it provides lab technical support and training for diagnostic that are needed for surveillance and emergency outbreak response. And actually, all the member states at the region are benefiting from the services of the AUB WHO Collaborating Center. And all this is possible due to the funding that's received over the past few years by CDC and CDC CRDF. And this fund actually supports generation of whole genome sequencing database and AMR of foodborne pathogens, tracking the source of foodborne illness in outbreak settings in the MENA region, supporting regional whole genome sequencing lab capacity building in Lebanon and the region, and training as well as implementing the whole genome sequencing in the MENA, especially for PulseNet participating countries. Now, as to cholera outbreak genomic surveillance that was done, so I don't need to define cholera, but the most important thing is that we have detected two different antimicrobial drug resistance profiles of Vibrio cholerae 01 isolates during this outbreak with different prevalence rates. So we had a major profile with a narrower resistance and a minor profile with an extended multi-drug resistance, which can be explained by two different scenarios. First, either one of the most prevalent, for example, let's say genotype, had an acquisition of a mobile genetic element that rendered a number of the bacteria that are circulating as MDR. So the mobile genetic element is a plasmid that has been acquired by the strain with narrower resistance profile. The second scenario, which is not common outside the Bay of Bengal, is the circulation of two different strains seeded separately into the Lebanese territory. That is, we had two different clones coming from different sources into Lebanon. We therefore applied the whole genome sequencing and the genomic epidemiology approaches to endorse one of these two scenarios. And we also delve into the genetic basis of the antibiotic resistance and virulence of the circulating isolates. So we used the different phenotypic methods, including culture, where we used, the TCBS agar, and we did also antibiotic susceptibility using the disk diffusion methods in accordance with the CLSI guidelines. And we have a panel of antimicrobial agents that were used. Now, these are the laboratories in the WHO Collaborating Center for culture. And also we had, following culture, we have done whole genome sequencing. And in whole genome sequencing, we are able to detect and fully characterize Vibrio cholera species, relying on genomic DNA extracted from the bacteria, and then providing high-resolution genomic typing method that can compare samples to sources, as well as contrast phylogenetic trees. So this is, again, the laboratory, the molecular laboratory where our whole genome sequencing and bioinformatic analysis has been done. So our results have found through the analysis that we have serogroup O1, serotype Ogawa, biotype L-TOR, sequence type ST69, and this is, the genomic wave 3, and the lineage belongs to the 7th pandemic Vibrio cholerae O1 biotype L-TOR. Now, we unexpectedly identified two different 7 PET strains, which are two different clones during this outbreak. So our second consideration was actually availability of two different clones, two different strains, and this is unprecedented in the region. Now, among these two strains, one strain is predominant and prevalent all over Lebanon and related to isolates found in Pakistan. So it is identical phylogenetically to the isolate in Pakistan. And the second was similar to the MDR strain, which is identical to that of Yemen that has occurred in the late 2018. Now, the phylogenetic analysis have found that we have two strains fueled in the cholera outbreak. This is one strain. Over here in red is the data from Lebanon, and this is comparable to Pakistani isolates. And so one strain, therefore, is similar to that of the strain of Pakistan, and it is the most prevalent one. And we had 656 that were out of 681 lab-confirmed cases. Now, the second strain is similar to the Yemeni MDR strain. It is less dominant. So we had a total of 35 isolates out of 681 that were lab confirmed. Now, what we found that you see in that circle, you have the blue represents the dominant strain. Now, this dominant strain is sensitive to most tested antimicrobial agents. While it was resistant to nalidixic acid, perfloxacin, and nitrofurantoin, and it was intermediately sensitive to Cipro and Levo. While the 35 isolates that are identical to the Yemeni strain, these ones are mostly resistant to a panel of antimicrobial agents: cefotaxime, ceftazidime, nalidixic acid, perfloxacin, erythromycin, azithromycin, trisulfa, and nitrofurantoin, while sensitive to tetracycline tazobactam, doxycycline, meropenem, and colistin, and intermediately sensitive to Cipro and Levo. And over here, we see the analysis of the genes that are encoding for resistance to the stated antimicrobial agents. So whole genome sequencing actually provided an unprecedented understanding and characterization of Vibrio cholerae outbreak. However, we have limited studies from the Middle East and North Africa region that is actually harnessing the power of this technology. So all these investigated outbreaks, as many other worldwide outbreaks, have been caused by one strain following one single introduction, in contrast to the endemic setting where several lineages could co-circulate. Now, with regards to Lebanon, one manuscript addressing the history of cholera in Africa from genomic perspective has assigned 3 Lebanese strains from the past 1970 and 1993 outbreaks as O1 Ogawa isolates from wave 1 and 2 of the 7th pandemic lineage. Okay, we provided actually in this study a comprehensive overview of the molecular epidemiology of Vibrio cholerae causing the cholera outbreak in Lebanon for the first time. And the integration of the whole genome sequencing allowed us to delineate with high discrimination 2 phylogenetically distant strains, one with origin from Pakistan and the second from Yemen. So being of different susceptibility patterns, the WGS actually enabled us to exclude the most likely hypothesis of the emergence of the multi-drug resistance minor strain from the susceptible dominant strain by acquiring the plasmid, but rather confirming that there is two different clones, 2 different strains with 2 different clones that are responsible for the outbreak. Now, this study actually evidences again the importance of whole genome sequencing associated with national surveillance in gaining new insights and perspectives into our perception of Vibrio cholerae outbreak. Now, the occurrence of an unexpected 2-strain outbreak in a setting considered non-endemic for Vibrio cholerae requires a tight train from the authorities to avoid the sporadic introduction and pervasion of additional strains. Now, one question that arises is to what extent these identified strains, especially those originating from Asia, have swept the neighboring countries that declared cholera outbreaks before Lebanon, namely Iraq and Syria. So answering this question is quite challenging due to the lack of strains from these countries. Now, regional surveillance of the cholera agent is therefore an utmost need to closely untangle the transmission events and keep a watchful eye on the emergence of antimicrobial resistant strains as witnessed in many worldwide countries. So in conclusion, the outbreak in Lebanon was caused by 2 different strains, one with a narrow AMR profile related to isolates in Pakistan in 2022, and the other one with an extended AMR profile related to the Yemeni Vibrio cholerae strain. Now, the limitations is that the isolates from close neighboring countries are missing from the phylogenetic analysis. So, to that purpose, a regional surveillance of the cholera agent by microbial genomics is thereby paramount to reliably infer the routes of transmission and track and monitor any emergence of AMR-resistant strains as witnessed in many worldwide countries. Now, also, I'd like to mention about the training that we have offered actually in September of 2023. And this is an EMRO, Eastern Mediterranean Regional Office of WHO, sub-regional training for national reference labs of acute watery diseases, priority countries, on advanced lab diagnostic and sequencing of cholera in Lebanon, September 2023. So this training occurred in the AUB Faculty of Medicine, WHO Collaborating Center for Reference and Research on Bacterial Pathogens. And we had 17 trainees from Oman, Somalia, Sudan, Syria, Yemen, Lebanon, Pakistan, Iraq, and Jordan. Now, the training provided actually hands-on whole genome sequencing and bioinformatics training to 17 participants, and the training in our center is done in collaboration with WHO, AMRO, UK Health Security Agency, and the University of Cambridge Bioinformatics Training Facility. And over here you can see a few pictures from that training. Now, finally, I would like to acknowledge my laboratory members at the AUB FN WHO Collaborating Center, and namely Dr. Abu Fayyad for his supervision of the lab operations all through the process, and all the staff in our WHO Collaborating Center. Also, thanks go to the US Centers for Disease Control and Prevention for scientific collaboration and financial support, the Ministry of Health for isolate collection, delivery of metadata, and prevention and control, the WHO for logistics and laboratory supplies, and also the Lebanese University for collaborations, and the Pasteur Institute for active collaboration in the study. Thank you. Thank you very much.